Good morning. My name is Csaba. I am from the International Psycho-Oncology Society, and I am welcoming all of you to the fifth LuCE report. Thank you so very much for your kind invitation. This morning, I am speaking to you from Cluj, Romania, and I am going to have a presentation on the psychological and social impact of lung cancer. We are going to start with the patientship. Of course, this is a word that I invented, but it certainly reflects the multidimensional burden of lung cancer on people affected by it, with all the difficulty of care. We are going to start with the psychosocial challenges in lung cancer. Patients with lung cancer are a neglected population in the area of psychosocial needs recognition and psychosocial care. They uniquely report among the highest added burden from stigmatization and are particularly likely to experience increased cancer distress. Stigmatization and smoking-specific concerns are of high importance because they are related to delayed treatment or maybe denied treatment, reluctance to disclose cancer status, and difficulties in asking for help, for example, in attending support groups. The negative psychosocial and behavioral implications of the health-related stigma are far-reaching for smokers compared to non-smokers. Patients with lung cancer are highly distressed before, during, and after cancer treatment. The overall prevalence rate of distress for lung cancer was found to be higher than 40%, and more than half of this population is interested in one or more psychological services. Actually, it was found that oncologists failed to identify distress in 68% of patients with lung cancer. Actually, non-disclosure, as we are going to see it, of the lung cancer diagnosis could be linked to the severity of distress in this clinical context. Depressive coping, emotional distress, and anxiety were all associated with shorter survival, respectively increased lung cancer-specific mortality, even after controlling for demographic, biomedical, and treatment variables. Diagnosed with lung cancer is one of the variables which is in the cancer diagnosis non-disclosure profile, together with being older, 55 years or above, with a mandatory or vocational education, living in rural communities, not receiving chemotherapy, male gender, advanced stages of the disease, and lack of cancer experience in the family. Speaking about family experience in lung cancer, it's very important to not blame the game. Actually, lung cancer patients' family caregivers reported up to 50% of clinically elevated distress, and more than 33% reported negative physical health as effects of caregiving. Lung cancer may be particularly distressing for family caregivers because of its high physical symptom burden, sometimes more of the time, poor prognosis and stigma, particularly when the patient persists in tobacco use. The family environment of blaming the patient during times of illness can affect both patient and caregiver depression alike. Blame or anger toward lung cancer patients may alter help behaviors or help-seeking behaviors and reduce communication between primary caregivers and patients. And it's not easy for family members because they're trying to coordinate everything. The majority, 74% of distressed family caregivers of lung cancer patients experienced one or more adverse economic or social changes since the patient's illness. And these hardships appeared even though most caregivers were from middle to upper class and most of them had health insurance coverage. Loss of the main source of family income and disengagement from most social and leisure activities predicted greater caregiver distress. The majority of the total economic burden experienced by informal caregivers of lung cancer patients, specifically 91%, arose from the direct effort of providing informal care to patients. So it's extremely timely and important to talk about caregivership. We are going to see caregiver skills, resources, and interventions. According to a white paper published by the European Cancer Patient Coalition and Eurocarers, carers already provide 80% of care in Europe, of cancer care. While people with cancer are often identified through their diagnosis, medical status, cancer carers often remain largely anonymous, despite their fundamental role that they play in the healthcare pathways. Only a total of 39% of cancer carers interviewed describe themselves as carers. And this is a very important thing because as we are looking to the physical side of caregivership, we see that cancer caregiving is related to increased blood pressure, dysregulation of the autonomic nervous system, and dysregulation of the stress axis of the hypothalamic pituitary axis, immune changes, and poor health-related behaviors, as you can see in this proposed model of the impact. Also, according to the Macmillan from the United Kingdom, 70% of carers, cancer carers, experience some form of emotional impact from caring. Almost 40% of spouse caregivers reported depressive symptoms in a range that is likely to be clinically significant, and this is a prevalence that is almost twofold that of their ill partners. And the marital dissatisfaction was found to be even more important contributor to depression than the objective caregiving burden. So it's very important to do this kind of dyadic investigations. And as you can see from the work of Professor Kim Young-mi from United States, for both patients and caregivers, poor mental health at the diagnosis posed significant risk to their physical health. Distressed patients showed stagnated physical health recovery, and distressed caregivers showed accelerated physical health decline. Caregivers' physical health declined mostly among those reporting low mental health at diagnosis and whose patients reported low physical health at diagnosis. Also, depressive symptoms predict cancer caregivers' physical health decline. This study, published by the same research group, actually provided novel information regarding cancer caregivers' long-term physical health decline. Only caregivers' higher depressive symptoms, so only this, predicted their accelerated physical health decline from 2 to 8 years following the cancer patient's diagnosis. Here you can see depressive symptoms and quality of life 5 and 8 years post-diagnosis among cancer caregivers. On the left, you are going to see that depression is a long-term challenge for this population. The first evidence that 5 years after the initial cancer diagnosis in the family, shows that many family members who remain in an active caregiver role or those who have become bereaved suffer from depressive symptoms, serious enough for concern. These findings, of course, highlight the importance of caregiving stress and social support early in caregivership. On the right, you're going to see the results from the 8 years post-diagnosis. This is the first evidence that family members who became bereaved by 8 years after the initial cancer diagnosis in the family suffer from poorer mental health and greater psychological distress years after the loss. Bereaved or currently caregiving family members at the 8-year mark reported poorer mental health and greater distress than family members of survivors who were in remission. So this is a highly important topic, which imposes actually to talk about requirements, essential requirements for quality cancer care in lung cancer, which is sometimes problematic, stigma sensitive, and hidden most of the time. As essential requirements for patients, we believe that distress and quality of life concerns of patients with lung cancer should be addressed, monitored, and treated promptly and as clinically indicated throughout the disease trajectory. The empirically validated distress thermometer is acceptable for rapid distress screening in the oncology context, as it opens up communication on psychosocial burdens and significantly reduces time to referral. Failure to detect cancer distress, as we have talked about in the introduction, as well as increase the levels of distress in lung cancer patients, might serve as barriers to treatment, decreasing patients' health-related quality of life, increasing health care costs, and negatively impacting smoking cessation efforts. As essential requirements for caregivers, we think that policymakers must formally recognize the role of carers and provide appropriate welfare programs, including paid carer leave, flexible work arrangements, financial compensation, and pension rights. Carers must have access to programs, including information, training, and psychosocial support, and must be included in the patient's care team. Carers must be encouraged to identify themselves as carers and take part in support programs, given that many do not identify with the term, as we have seen from the ECPC report. At European level, governments must adopt the New Start initiative for work and life balance for parents and carers proposed by the European Commission. Of course, psychosocial interventions are beneficial. Overall, 65 of the studies led to positive and significant improvements in functioning for informal caregivers and patients for whom they provided care. And it's extremely important to highlight that couple-based interventions have similar effect sizes, are as beneficial as are the patient-only or caregiver-only interventions. The increased use of smartphones, telephones, and alternative modalities nowadays during COVID-19, like Skype, Zoom, for intervention delivery is likely one solution or one of the solutions to the barriers of delivery. Web-based interventions actually may reduce negative mood in caregivers of patients with cancer. Web-based caregiver and patient intervention are as effective as traditional interventions, although at this point, quality of current web-based caregiver interventions is weak in lung cancer. I would like to kindly thank you for your attention and invite all of you to our next meeting at ECHO, a roundtable meeting on lung cancer on 7th of December, when we are going also to launch the new paper on ECHO essential requirements in quality cancer care for lung cancer patients. Thank you so very much, and I am looking forward to the Q&A session. Thank you.